good morning, and good afternoon, good evening, wherever you are, in whichever part of the world you are. I welcome you all to this exciting session on stereotactic radiation therapy. We have an eminent group of speakers with us today. First of all, I would like to introduce Professor Tracy Balboni, who is Professor of Radiation Oncology at Harvard Medical School. She's also a clinical director of supportive and palliative radiation oncology. She is program director at Harvard Residency Radiation Oncology Program. She has more than 100 publications and she has edited more than 11 books, probably 15 editorials, and she has written a book also. But this is we are much honored to have her with us today. I will not be in between Tracy and you. Tracy, how are you doing? Welcome you on board.
Oh, thank you. I'm just delighted to be here with all of you. I wish I could be there in person.
Oh, we all wish you to. And with this changing scenario today, I think I'm the first one to say you, I don't know whether to say congratulations on the new president, Joe Biden.
Yes.
And let's hope it's good for America and the rest of the world.
I think so.
Yeah. So please, we are anxiously waiting to hear from you. Thank you.
Wonderful. Well, I'm so honored to be a part of this wonderful event. So thank you for inviting me. If it's okay, should I go ahead now and share my screen?
Yes, please.
So what I'm going to be speaking with you all about today is this really emerging area of the use of stereotactic body radiation therapy in the management of spine and bone metastases. Certainly it isn't all that novel. It's been done for at least the last decade or two, but increasingly, especially within the last several years, we're seeing increasing evidence for a variety of applications of this technology to the benefits of our patients. I'm going to be sharing that with all of you today. So we're going to be covering three separate kind of applications of stereotactic body radiation therapy to bone metastases, thinking about spine as well as non-spine bone metastases. So first we'll speak about that in the context of oligometastatic disease. Then we'll consider stereotactic body radiation therapy in this setting of reirradiation to bone metastases, in particular to spine metastases where the spinal cord and other neural structures are in play. And then finally, we will consider a stereotactic body radiation therapy in the palliation of painful bone metastases with some very new data coming out in this regard as far as its potential utility in this setting as well. So first, data informing Sbrt for oligometastatic disease. I'm going to do this in a case-based fashion. We'll have a case, I'm sure there'll be cases familiar to all of you that we see, but just to provide some context within which to be applying these data. So the first is a woman I saw not too long ago, a 61-year-old woman. Her ECOG was 1 only because of some symptoms of back pain. She had a prior history about a year prior of an EGFR mutated non-small cell lung cancer of the lung, stage 2A. She was treated with definitively managed with a right upper lobe lobectomy. But now it's a year later and she's admitted with this fairly severe low back pain. It's quite mechanical in nature. So when she's up and about or getting up out of bed, she really notices the pain more severely, although she also, in addition to that, notes a right lower extremity radiculopathy. So she undergoes a workup, which includes a PET CT scan, which I'm showing to you all today. And it shows PET avid disease at 3 sites. And that included the L5 site, which I've shown to you below, involving a good portion of the vertebral body itself, with some lytic portion of the disease. You can see here on the sagittal image that the lytic portion is actually cause some degree of mild collapse as well. She also has disease at S1 and the right iliac wing. There's no other sites of disease, and her pain management is optimized with the assistance of palliative care. I'm just going to show you the other side. So she has another site in the posterior element sort of S1, so in the posterior aspect of the sacrum, as well as in the right iliac wing. So here is a woman with 3 sites of oligometastatic disease. Her primary is controlled. She's had definitive management of her primary a year ago. And in her case would have certainly been eligible for this study. This is the Sbrt Comet study, which is a phase 2 randomized control trial of nearly 100 patients with oligometastatic disease. This was all histologies having 5 or less sites of oligometastatic disease. So as you may know, the definition of oligometastatic disease varies. Anything from 3 to 5 tends to be the definition. And they were randomized to receive either stereotactic ablative body radiotherapy versus standard of care alone. And their primary endpoint was overall survival. These are the Sbrt details in regard to the dose fractionation schemes that they use. I just want to point out that for bone metastases, the regimen was 35 and 5 for the 5 fraction regimen, 30 gray in 3 fractions for a 3 fraction regimen, and then 16 to 20 gray in a single fraction. And I will say that tends to be the regimen that we choose in our own setting, although that does vary from center to center. And as you likely have seen in the publication in Lancet in 2019, they showed a very notable progression-free survival benefit, a median of 6 months in the control arm versus 12 months in the Sbrt arm. And they, at this time point, had a trend toward an overall survival benefit, but it did not reach statistical significance. However, just at ASTRO recently, we had the update of the Sbrt Comet study showing at this point that there is now an overall survival benefit. So the median overall survival being 28 months in the control arm versus 50 months in the Sbrt arm. So quite a dramatic difference in overall survival between the 2 groups. And again, this was statistically significant. They did note that many of the patients who received Sbrt actually went on to receive additional courses of Sbrt, about 30% subsequently. And we do often see that in practice, that patients who, like this patient I just presented to you, oftentimes will come back with an additional site or 2 that requires further Sbrt down the road. So there's other data in oligometastatic disease, and I'm just going to provide a few examples of those. So for example, this study published in Lancet Oncology in 2016 with an update in the JCO in 2019. A smaller study, 49 patients with newly diagnosed oligometastatic non-small cell lung cancer with 3 or less oligometastatic lesions. So again, our patient would actually fit quite nicely into this trial. They could not have had progression after first-line therapy, and they were randomized to either local consolidative therapy, which was largely Sbrt, although they did do some surgery, versus maintenance alone. And there was a progression-free survival benefit, 11.9 months versus 3.9 months in patients receiving Sbrt. And the update in 2019 published in JCO now shows an overall survival benefit to the addition of Sbrt to maintenance therapy, 41 months versus 17 months in the control arm. This is data pertinent to the setting of non-small cell lung cancer. There's also data pertinent to the setting of prostate cancer. This study published in JCO in 2018, 62 patients with oligometastatic prostate cancer, defined as 3 or less oligometastatic lesions, randomized to receive metastasis-directed therapy, which again was largely Sbrt, though not all, versus surveillance, finding a ADT-free survival benefit in patients receiving Sbrt, 21 months versus 13 months in their surveillance arm. So how did we manage this particular patient case? As you can see, she would qualify both for the Sabre Comet trial as well as the Gomez trial that I just noted to you. And hence, after a presentation in our multidisciplinary spinal tumor conference, we proceeded with Sbrt. And because of the extent of her disease, and we did this all in one field, treating these 3 sites because of their close proximity to one another, we ended up treating her 235 Gray in 5 fractions. Generally, when we're closer to other neural structures or have a larger volume that we're treating, we're doing a 5 fraction regimen. She did have evidence of instability. I showed you the fact that she had a lytic lesion. It's at a stress point within the spine, being at a transitional point in the spine at L5. She also had some degree of fracture, and she had mechanical pain. And hence, we did have a consideration for surgery for her, but ultimately chose to proceed and thought she would be a good candidate for IR plasty. So this was her plasty procedure that she had shortly after completing her Sbrt, and her pain entirely resolved between the Sbrt. She had marked improvement after that, and then further improvement after placement of cement via IR plasty, and then started osimertinib. So with that, that's kind of a quick whirlwind tour of Sbrt in the setting of oligometastatic lesions. Let's consider Sbrt in the setting of reirradiation. More and more often, I think, especially as our therapies improve for the management of advanced cancers, we find that we're oftentimes needing to re-irradiate a region, and Sbrt can be a means, particularly in the spine, to minimize reirradiation doses to normal structures. So I'm again going to be presenting you with a case. This is another patient who I saw recently, a 68-year-old gentleman with a history of Hodgkin's lymphoma, treated 42 years ago. He received chemotherapy and radiation therapy to the head and neck region, 36 Gray and 18 fractions. But then in 2014, he developed prostate cancer, which was definitively managed, but then he was noted to have a rising PSA, and as part of his workup with an Aximum PET CT scan, he was found to have a single site of metastatic disease at C7, shown here on the Aximum PET CT scan. But of course, this is the region where he's received prior radiation therapy, 36 Gray and 18 fractions. So how do we approach spinal reirradiation? Of course, this is, again, a very frequent clinical scenario that we run up against with the spinal cord as our dose-limiting structure. There is data from the conventional reirradiation setting, so not with Sbrt. These are 2 older studies which have really kind of begun to create sort of a map for how to approach these patients and how to retreat these patients based on 78 cases of reirradiation, 11 of them with myelopathy. And they noticed the characteristics and looked for predictors of proceeding to myelopathy among these patients. And what they found was that cumulative BED grade 2, so assuming an alpha beta of 2 of 135 or less, keeping the interval at least longer than 2 months, and keeping the BED of any individual course less than 102 were all ways to protect the patient, would have a lesser risk of proceeding to myelopathy. And so based on that, they created this scoring system where, based on that cumulative BED grade 2, again, assuming an alpha beta of 2 for cord, an interval of less than 6 months, and a BED course of 102 grade 2 or higher, this kind of maps out the degree of risk that one might have with reirradiation. So for example, in the current case that I just presented to you, we considered he had received around 78 grade 2. And so we were keeping him to within about 140 cumulative grade 2, which would be 2 points in the score. His interval, of course, between courses of treatment was well above 6 months, and no course was greater than 102. So that gives him a score of 2. That keeps him in the low risk category for any development of myelopathy down the road. And again, this is how, of course, this is calculated. Of course, you can there's many apps. I typically have an app that I use. I imagine others do as well, in order to, as we're constantly dealing with cases of reirradiation with various prior doses. What's interesting is if you look at the more recent Sbrt literature looking at reirradiation and risks of myelopathy, the data are actually notably similar. So, for example, this study published in the Red Journal in 2011 by Arjun Segal and others noted that they recommended, based on their own examination of predictors of proceeding to myelopathy in cases of Sbrt reirradiation, recommended keeping the cumulative point max to less than what is the equivalent of 70 gray in 2 gray fractions. And assuming an alpha beta of 2 for cord, that's 140. So very similar to what we see from the conventional reirradiation data. So generally, we in our reirradiation cases attempt to ensure that the cumulative BED grade 2 is about 135 to 140. And stick to that to keep the myelopathy risk low, in addition to keeping the interval greater than 6 months or more, and being careful about any single course being a very large BED grade 2. There is data on Sbrt for reirradiation, some of it retrospective, but some prospective studies. So for example, at the Beth Israel Deaconess Medical Center in Boston, they reported on their cases of using either a regimen of 8 gray times 3, or 24 gray in 3 fractions, or 6 gray times 5, 30 gray in 5 fractions. And in these 81 cases, at 12 months, they had a local control rate of 93%, so good local control. MD Anderson also has a phase 2 study of reirradiation using either 9 gray times 3 or 6 gray times 5. It was actually predominantly 6 gray times 5. And they had a 1-year local control of 76%. So applying these data to this current case that I presented to you, we chose to proceed with Sbrt for his single site of metastatic disease, keeping his cumulative BED to less than 140. He was slightly less than 140. And his prescription dose was 30 gray in 5 fractions, sort of our typical reirradiation Sbrt dose. And this is his plan shown below, fused with a planning MRI. We do have both a CT sim and an MRI sim that we do in order to ensure good fusions for these cases for good demarcation of the spinal cord. And in addition, at times, we'll also additionally do myelograms to define the spinal cord. So finally, I want to consider this, this next setting, which with some more recent data, and that is Sbrt for painful bone metastases. And again, I'll present a case. This is a 57-year-old gentleman with metastatic clear cell renal cell carcinoma. He has widespread bone and lung metastases. He's actually had his disease for about 6 years. And currently all of his disease is under good control, except for this single progressive and very painful site within the manubrium, which I'm showing you here on the sagittal image and here on the coronal image. There has been some recent data suggesting that Sbrt may be more efficacious in bringing about good pain control as well as local control in these patients. So this is a study out of MD Anderson, a phase 2 randomized controlled non-inferiority study of 160 patients with painful non-spine bone metastases. So our case that I've presented would fit with this study. They were randomized to receive single fraction Sbrt, 12 to 16 gray, depending on the size of the lesion, versus multi-fraction radiation. And they used what is a very typical regimen for us here in the United States, which is 30 gray in 10 fractions. And their primary endpoint was pain response. And as you can see, the pain response at 2 weeks, 3 months, and at 9 months was higher in the Sbrt arm, markedly higher in the Sbrt arm as compared to the multi-fraction arm. Interestingly, additionally, this is one of their secondary endpoints, they found that Sbrt had better local control as compared to multi-fraction radiation therapy. at 1 year, 100% versus 90%, and at 2 years, 100% versus about 76%, suggesting that the higher doses of Sbrt may be more efficacious for local control as well as pain control. Just at this last Astro, Arjun Segal presented this study out of Canada and Australia, a randomized phase 2/3 study comparing 24 gray in 2 Sbrt fractions versus 20 gray in 5 conventional radiation fractions in patients with painful spine metastases. So the prior studies was non-spine bone. This is explicitly in spine metastases. Their primary endpoint was achieving a complete pain response at that painful site. They used the International Spine Radiosurgery Consensus criteria for contouring, which of course defines the vertebral bodies into regions, and it's based on the regions involved, as shown here from the table from that study, that defines then what the ultimate CTV will typically be. That's shown pictorially here in this diagram also from that study. So they followed the international consensus guidelines in contouring these spine cases, and 229 patients were randomized. They found no difference in baseline characteristics. What they noted and reported at this year's Astro was at 3 months, complete response rates were over double those seen in conventional radiation therapy. So 35% versus 14% in the conventional radiation therapy arm. And that finding held out to 6 months for complete response rates. As far as side effects, there was no difference between groups, no cases of myelopathy. And one concern, of course, is that fractures could be higher in patients receiving Sbrt, but the fracture rates at 6 months were 11% in the Sbrt arm versus 17% in the conventional radiation therapy arm, suggesting at the least that Sbrt is not causing greater fractures. If anything, in this study, conventional radiation therapy was at least numerically slightly higher as far as the rates of fracture. I do want to contrast this study to last year's reported RTOG 0631, which was a somewhat similar study. Again, painful spine metastases randomized to receive either 16 or 18 gray radiosurgery, so it's single fraction Sbrt, versus 8 gray and a single fraction, again, with the primary endpoint of pain response. But in this case, as opposed to complete response, the pain response had to be 3 points, a 3-point decrease in their pain on the 0 to 10 pain scale. And notably in this study, there was no difference between the groups. So there was quite a bit of discussion at this year's Astro about why there was a difference between these two studies. Some possibilities include the fact that there were some noted differences between the trials. So, for example, RTOG 0631 required a pain score of at least 5 or greater. So much higher pain scores as compared to the Canadian trial, which required scores of just 2 or higher. So they had patients started out with less pain. Other data does suggest that pain response rates are better when patients start out with lesser pain. So that might be one of the reasons. Other reasons include the fact that the Canadian trial excluded patients with spine instability, but the spine instability and neoplasia score wasn't developed by the time of this RTOG trial's development. It was developed earlier. And so though they used fracture as an exclusion criteria, they didn't have any other measures of spine instability to exclude patients. So these are possibilities of why there were differences between these two studies, but really we need more data to guide us as far as really understanding the applicability of Sbrt for painful spine metastases. So returning to our case of this gentleman with a painful metastasis within the manubrium and sternum, he received 18 gray in a single fraction, and he had an excellent near complete response even at 3 weeks. 3 weeks out from his treatment. So this is his, just wanted to say a little bit about setup for these patients. So as you can imagine, they are within what's called a Cisco board, which is MR compatible because they undergo CT and MRI SIMS. As part of their imaging protocol, we do have surface imaging in order to help to get them into position as part of their initial positioning. You can see that here. So surface monitoring system, followed by 2D, 3D setups, and then cone beam CTs, and then the surface monitoring throughout the treatment in addition to the imaging that I mentioned. So just in summary, we've did a whirlwind tour of Sbrt for bone and spine metastases. There's really emerging data, primarily phase 2 randomized controlled trials, but more data certainly to come, that suggest improved outcomes with Sbrt for oligometastatic disease. And of course, that includes bone metastases, as we've outlined. Data do support Sbrt re-irradiation for the spine, and we have parameters of how to keep the spine safe, in particular, keeping the cumulative BED grade 2 to within about 135 to 140. And there's emerging phase 2 and even phase 3 data that support Sbrt for painful bone metastases with possible benefits to pain control and local control. But again, more research work needs to be done to clarify the role of Sbrt further. So with that, I just want to thank you again for inviting me to be a part of this wonderful event, and I'm happy to take any questions.
Thank you so much, Tracy. That was a wonderful talk, actually. I'll take some time because we still have 4 minutes, and I will, yeah, and I have a couple of questions. So the first one is, while treating 2 lesions, can we give 2 different doses simultaneously, or treating one followed by another if they are 3 centimeters apart?
So this comes up very frequently. So, and we have to make a decision because, you know, ultimately, you can dose paint to different doses, but the fractionation is going to be the same. So sometimes that is workable, but like in the case that I showed you, the first case of the woman with 3 lesions in very close proximity to each other, we ended up doing the same dose to the 3 regions. You know, that being said, you know, we have other cases where they're just a little bit further apart and you're having to deal with the question of whether you include it as one plan, which can then be optimized across both, as opposed to 2 plans where you can't necessarily optimize the planning together in one setting. So we have a couple, you know, sometimes we try it one way and then try it the other, but it's a little bit, it gets gray, especially when they're quite close, but still far apart. That comes up frequently for us.
Oh, thank you so much. The other question is regarding spinal mets. Could you just tell us about probable beam arrangement used? I know this is more of a physics thing, and any role of non-coplanar beams when you are treating a spine.
With Sbrt?
Yes.
Yes. So we always use planar arcs. So it's all VMAT planning for these patients. And generally we found that is the most optimum for the spine. I understand that for other Sbrt sites that is not necessarily the case. I think it's just the location of the spine, its configuration makes that the most optimal in our experience. Although I know for things like lung Sbrt, et cetera, that isn't necessary. That's not always the case. But in the spine, for us, we find that's optimal.
Okay, last question. Any specific dose coverage and goals, and what is the maximum dose will you accept within PTV?
So we generally, I mean, there's a lot of variation center to center in this regard. We tend to aim for 125% for our cases as far as dose max within the PTV. That being said, we'll oftentimes allow that to go much hotter, especially if it remains within the PTV. So, but that's generally our starting point. And as far as coverage, We generally will do a volume that's the GTV plus our PTV margin, and the spine, our PTV margin is a millimeter. And that will often ask for, even upwards of 97 to 99% coverage of that. So you can imagine the hot spots can get quite hot. Whereas the CTV, briefly showed you the international consensus guidelines, will, allow for around 95% coverage, et cetera, because it's the CTV that oftentimes is right up against key structures that you're going to have to avoid and do some sacrificing of coverage in order to meet your metrics.
Well, thank you so much. That was so exciting, Tracy. And I really thank you. There are a lot of other questions also, but perhaps I can send you email and we can.
Oh, I would love to respond to emails. Thank you.
Thank you. And we hope to see you here in Pakistan someday.
I would love to visit someday.
Thank you so much, Tracy.
Okay,
good night.
Thank you.
And if you want to stay with us, you are more than welcome, but I can understand that it's very late in Boston. So please feel free. Thank you so much. Thank you.
Thank you.
Thank you. Thank you. Bye. So with this, we had a very excellent talk on spine and bone Sbrt. My next speaker is Dr. Lubna Hamoudeh, who has done her CNS fellowship at Brigham and Women's Hospital, Dana-Farber Cancer Institute, Harvard Medical School, and now she is doing a second fellowship in her supportive and palliative radiation oncology. She will talk to us about CNS stereotactic radiation, and I hope this will be very, very exciting topic. Thank you so much. Over to you, Lubna.
Thank you, Dr. Farid. Thanks, everyone. I'm very happy and so grateful to be a part of this meeting today. And can you hear me well?
Yes, we can.
Okay, should I proceed and share my screen?
Yes, please.
Okay. So today my talk would be about stereotactic radiosurgery for brain metastases. So as you all know, the reason we discussed the brain metastases as it is the most common type of intracranial tumors and represents around 40% of patients with cancer that may develop brain metastases. So it's almost 50% of the primary brain cancers that we can see represents as brain metastases. And in the current era, we can really notice that brain metastasis has become more increasingly seen due to improved the diagnostic workup technique and the early screening, staging workup done to the cancer patients, increased cancer prevalence, the approaches of systemic therapy and targeted and immunotherapy used for patients. So we've been seeing those more and more with the latest years. And lung cancers represent the most common a primary that represents for brain metastases, followed by breast and melanoma and other primaries. So the most common, the most important modality that would guide us to delineate the brain metastasis lesions is brain MRI post-gadolinium, post-contrast. And it should be with thin cuts, like 1 to 2 millimeter thin cuts, so to identify even small lesions. Other sequences that could help us to confirm and make sure of our findings is to rely on the T1 pre-contrast, the SWI, and the T2 also to show the edema and flare. So for example, in this case scenario, this is a patient who had brain metastasis lesions located at the cerebellopontine area, which was resected. And this is the T1 post-GAD that showed the enhanced area after resection. And so when you look at the T1 post-contrast and showed this enhancement, you could argue that this is represent a residual disease versus, surgical changes, post-surgical changes and blood products. So the one thing that could help to assess with that is to pull up the T1 pre-contrast and look at the same level. So here it's not really aligned well because of the different slice thickness, but I would say that there is a brightness there in the T1 pre-contrast, which confirm that this is post-surgical changes and blood changes is there, because if it's residual disease, that would not be seen well with the T1 pre-contrast. And then the SWI confirmed that's really better assessment, because in SWI, the blood products would represent itself as a bright center with a black rim around it. So in that way, we can confirm that this patient had achieved a gross total resection after his surgery. And what we're seeing as an enhancement after surgery is just surgical changes. And that's really important because that's also could affect our decision on how to treat, to boost the residual disease versus to treat the cavity. And sometimes some institutions would argue to observe the cavity post-surgery if the patient achieved gross total resection. So from the other differentiations that could enhance in the T1 post-contrast is to keep in mind like fat, protein, methemoglobin, and melanin. Those are things that could, make us a less, not everything is bright like it should be a brain metastasis. And other brain metastasis could represent itself as hemorrhagic brain mets that could easily be identified even in CT scans. In CT scans, and those hemorrhagic brain metastases from melanoma primary, choriocarcinoma, renal cell carcinoma, thyroid cancer could represent itself as hemorrhagic brain mets. So as we all know, per NCCN guidelines, doing a brain MRI in asymptomatic patients recommended only for specific primary cancer patients, like the small cell lung cancer, stage 1B to 4 non-small cell lung cancer, stage 4 melanoma. And there are some of the papers that was published to highlight the importance of doing those MRI brain as a staging workup for breast cancer patients, as it's very, we see it very commonly, especially in triple negative breast cancer patients and maybe young age, but there's still no evidence that this is, would be like, straightforward guidelines recommends doing that. And when we talk about brain metastases, we should keep in mind other differential diagnoses like other primaries, such as astrocytomas, GBM, lymphoma, and abscesses. But I would say like each of these entities have its unique differential and radiological features that could identify itself more than the other. So when we look at the metastasis lesions, most commonly it's located in the gray-white matter junction with enhanced T1 post-contrast and well-circumscribed lesions, while in gliomas it is heterogeneously enhancing and could be multifocal and cross the midline. In lymphomas, it is homogeneously enhancing and most commonly located in the periventricular area, and the abscesses would represent as a ring enhancing as a typical radiological features to show itself. So now when we have a case of a patient with a brain metastasis, there are a wide variety range of management approaches that the physicians could argue which to start with, starting from supportive care, like medications, using the steroids and anti-epileptic medications, regarding radiation, doing whole brain versus focused radiation, and maybe start with systemic approaches and targeted treatment. So the whole treatment decision would rely on the whole clinical scenario and the whole clinical picture of the patients, and we will discuss some of the cases in a couple of slides to just weigh in on how to deal and start with the best next step for those patients. For the CNS ASCO no joint recommendations for the prophylactic anti-epileptic drugs, I would say it's not recommended for routine use in patients with brain metastases unless those patients represents with seizures. So they have the, it's necessary to use the anti-seizing medication and to start with it, or the brain metastasis is located in the motor function area and motor strip that could have a higher probability of having seizures down the road, especially with large lesions and mass effects. And the same for the corticosteroids. So like I would say 5 years ago, it was recommended to be used routinely for every and single case of brain metastasis for patients who come for treatment with a stereotactic radiosurgery. But now it's not recommended as a daily medication to be used for every and single case, especially if there is no increased intracranial pressure and edema to those patients. So In Brigham, at least we use them and prescribe the steroids to start to be started to for those patients who have symptoms, and or maybe very highly probably to have symptoms because of the significant edema that we can see on their scans. So as we mentioned earlier, there are many factors that would affect physicians' decisions regarding the next treatment management plan for the patients based on their primary histologies, the number and size of brain metastases they have at presentation, if there is any symptoms, neurological symptoms versus asymptomatic patients, how is their disease status elsewhere in the body could affect also the management of their brain metastases, and if they are amenable for surgery versus systemic therapy options, and the overall prognosis. So here we can see that many of the papers highlight on the importance of the volume of the brain metastases in brain parenchyma that affects overall survival significantly in multiple papers with significant p-value compared to the number of metastases. And as we can see here in the figure, the first patients having up to 10 metastasis lesions with a cumulative volume of 5 cc versus the second patients have only 2 metastases with a cumulative volume exceeding the one before and equal to 8.4 cc. And that's really important because so deciding to do focused radiation to patients, the most important thing is the brain toxicity after doing the stereotactic radiosurgery, and that would really be affected by the volume of the lesions rather than the number of metastases, because when you calculate the brain tissue dose, the normal brain tissue dose minus GTVs, which is the integral brain dose, would be higher when the lesions are bigger in volumes, in cumulative volume, rather than their numbers, because here we can have a steep dose fall off around each lesion and we can spare more of the normal brain tissue, versus on those big lesions, the dose fall off would be more spread and scattered around the lesion given its size. So the normal brain tissue will be exposed to more radiation. So in that, the integral dose of the brain that is exposed to radiation is higher. And that's what's really concerning us from doing stereotactic radiation. Regarding the surgical resection approach, I would say it would be the best to do when we are not sure about the histologic confirmation of the malignancy the patient have brain metastases from. And it's usually shown a better overall survival and better disease-free survival when the patient have solitary brain mets, the body disease status is free elsewhere, and have better prognosis. As we can see, from patchel studies that compared doing surgical resection versus focused radiation for patients with solitary brain for 1 to 3 brain metastases, it doesn't show any significant difference in overall survival for any number of brain mets except for solitary brain mets. For solitary brain mets, it showed a difference in overall survival, 4 months for patients who received radiation alone versus 6 months for patients who received radiation after surgical resection. So it's very important whenever the patient have single metastasis with controlled extracranial disease and good performance status. So for many years, the whole brain radiation was the standard of care of doing, of treating brain metastasis, but starting in 1980s, the focused radiation was discovered by or delivered by the neurosurgeon who was the first one to combine the stereotactic methodology in LINAC-based with the surgical resection and other approaches for brain metastasis. His name is Lars Lexell. And the main goal of doing stereotactic radiation was to deposit the high dose of the radiation to the target and to reduce the dose surrounding to the healthy tissues with the use of a steep dose gradient outside the target. So here's the questions of, does SRS add to whole brain of any benefit? So in RTOG 9508, as we know, that was comparing a randomized trial that comparing whole brain radiation versus whole brain radiation added to it, focused radiation. It showed no difference in overall survival except for patients, so with no significant p-value, except for patients who have a single brain metastasis that received whole brain followed by focused radiation, which showed two months difference in overall survival with focused radiation added to whole brain. And also for a randomized trial in Patchell et al. That compared surgery in the treatment of single metastasis to the brain, it concluded that patients with cancer and single metastasis to the brain who receive a treatment with surgical resection plus radiation live longer and have a fewer recurrence rate in the brain with better quality of life too. And those two curves showed the overall survival difference with significant p-value and also the disease-free survival and time of recurrence. So again, to highlight on the importance of surgical resection for single brain lesion for patients who has solitary brain mets and controlled disease elsewhere in the body with good care performance status would reflect a better overall survival on those groups. Now the questions would be, since SRS didn't add to the whole brain for majority of patients, can we avoid whole brain for patients with 1 to 3 brain metastases? And here the answer would be from multiple trials that was done and multiple papers was published, like Patchell 2 in 1998 and the Japanese trial in 2006, MD Anderson trial in 2009 and the ERTC and the NCCTG. All those trials showed that adding whole brain to the surgical approach or to the focused radiation approach would not affect overall survival and showed no difference in overall survival, no difference in quality of life, but maybe worse quality of life and worse neurocognitive function outcome when adding whole brain to those approaches. So from that point, whole brain minus hippocampal area was raised to be started as a regimen to be done for those patients to avoid neurocognitive toxicity. And RTOG 0933 was the first one to investigate that and avoiding hippocampal radiation with a maximum dose of less than 16 gray from that specific plan and mean dose of less than 9 gray. And that would, the prescription dose that was used in this paper is 30 gray in 10 fractions. And we all know that should be in VMAT because we can't spare the hippocampus with doing like the 3D conformal planning. The PTV coverage was confirmed to be a 25 gray for 98% of the volume. And the Dmax should not exceed 37.5 gray, and of course, to avoid the optics from having any of those D maximum. And there is the hippocampal contouring atlas that guide to contour the hippocampal area. But for the sake of time, I would skip sharing this. Now, there are other data that support treating brain metastases for more than 4 lesions with focused radiation. So one was the Batanger et al. And the other, the Yamamoto et al. That discussed more than 4 lesions, up to 10 lesions in Yamamoto et al. But it's important here to mention that in Yamamoto et al., the maximum number was 10 lesions, but the cumulative volume of those lesions were not exceeding, I believe, 1 cc. So the cumulative volume, as we mentioned earlier, is important prognostic factor more than the number of metastatic lesions in the brain to decide whether to proceed with focused radiation versus not in multiple brain metastases. Regarding the simulation of stereotactic radiosurgery, here in Brigham, we use the Q-Fix Encompass mask double-layered at chin area and fuse that with the T1 post-contrast that is done in thin cuts of 1.5 to 3 millimeter for better delineation of the target. And there are, as you all know, different kind of thermoplastic masks that could be used as a non-invasive stereotactic immobilization system. And here, everyone should be aware for the setup error margin of each type of thermoplastic masks that should be taken in consideration whenever we want to approve the cone-beam CTs pre-treatment and during the treatment. So there are types that have 2.2 millimeter setup error, and while like the brain lab thermoplastic mask has only 0.5 millimeter, so that would affect the, you know, the PTV and the penumbra and the cone-beam CT before treatment proceeded. For the daily setup, some institutions rely on doing exact tract and vision radiation. Others rely on doing cone-beam CT. In Brigham, we do both. For exact tract, we could accept a focused radiation coordinates margin deviation of up to 0.7 millimeters and 0.7 degrees rotational. For the stereotactic radiotherapy, which is the fractionated approach of the focused radiation, we would accept up to 1.25 millimeters in XYZ and 1.5 degrees rotational. The cone-beam CT is important for the anatomy check on bone and soft tissue window, and the edema too, excuse me. And also the cone-beam CT could be used, so usually it should be done pre-treatment, and then if it's relied in a very perfect way, it's not necessary to repeat that in between arcs, but some institution would argue to repeat that in between arcs, and others would confirm to do it at the end of the treatment, and that would help for the setup error fixation for the next day. Here is how to, you know, just imagine how's the rotational by the x-axis, which is the roll, and then the y is the yaw, and the pitch is the rotational degree of rotational deviation. The most important paper that specified the dose recommendation of focused radiation based on volume of the lesions is the RTOG 9005, which recommend 24 gray for each lesion to 20 millimeter or less, 18 gray for any lesion to 20 to 30 millimeter, and 15 gray for any lesion beyond 30 to 40 millimeters. Regarding post-operative stereotactic radiosurgery versus observation to the cavities after resection, so it showed that focused radiation to the cavities after resection would show less recurrence of the tumor at the site of surgery, and that was published by Mahajan et al. And this local recurrence would be 50% less of having the tumor rise again at the site of surgical resection. And on the other hand, there is 50% that that there's no recurrence at that site without even radiation. So in Brigham, we do stereotactic radiation with a fractionated regimen to every and single site after surgical resection. But for example, over Mass General Hospital, they would probably argue and just observe because the recurrence rate is 50%. So I think their principle is just why do we harm the normal tissue if the cancer is resected out already, and harm the normal brain tissue with radiation if it's like 50-50, even if it's 50% less, but it's 50% not to have anything. So it depends on how, so I think here there's an argue of how to proceed with, and either way should be fine based on our data, based on the data we have. But at least I believe, like in patients with good performance status and good controlled disease elsewhere in the body with young age, it's worth to just proceed with radiation and make sure to better control the area. And this focused radiation after surgical resection does not affect the overall survival of those patients and does not affect the recurrence elsewhere in the brain. And the way that the radiation of surgical cavities should be radiated is with fractionated radiation, better of having one single shot of stereotactic radiosurgery. The reason of that is not to harm the normal brain tissue, again, because the cancer is out already. So respect the radiobiology and normal brain tissue protection. And usually we prescribe a dose of 25 grain, 5 fractions in Brigham. There are some institutions that could argue based on other papers to radiate the surgical cavities with whole brain radiation rather than focused radiation. And also in Johns Hopkins, also there was a study to focused radiation with one session for the surgical cavities too. So regarding the target delineation, we would rely on the brain MRI with T1 post-contrast with thin cuts. We will consider a 1 millimeter PTV for intact lesions and 2 millimeter PTV for the cavities. And the reason is because the ACR and ASTRO guidelines targeting for the intracranial metastasis to be approximately 1 millimeter as infiltration dose of brain metastasis, which is a small and to lessen toxicity. And that's why the small cell lung cancer, we would not recommend doing focused radiation because the infiltration dose is beyond that. It may exceed up to 3 centimeters infiltration. And we will prescribe our dose in LINAC-based stereotactic radiation on the 80 and 90% isodose line, whether in Gamma Knife it's in 50% isodose lines. And most of the times we use the 6MV because it's superficial lesions. We don't need higher energy to be used.
I'm sorry, Lubna, we have only 3 minutes.
Okay, thank you, Mohsen. We should cover the GTV with 100% of the prescription dose and the PTV almost 99, 98%. We should respect the metrics of the V12 to be less than 10 cc. And the reason why, because it showed that the V12 less than 10 cc is the metric where the radiation necrosis would be higher after that. So we usually try to just respect that. You could argue of other metrics, but it's all based on the radiation necrosis rate. It's usually in non-coplanar fields and with VMAT radiation with 4 to 6 partial arcs. And those are the metrics that we rely on to approve our plans. There are some cases that we may face that have like some enhancement in T1 post-contrast, and they have well-controlled systemic treatment and no probability of having brain metastasis, and their MRI sequences in DWI-ADC to show any ischemic changes doesn't show and identify any lesions. In those cases where you're suspicious of having any brain metastasis, that just watch and see, especially if the patient is asymptomatic, and repeat your scans. In this case, we have this patient and we repeat MRI after 3 weeks, and those enhanced lesions disappeared by itself, and we didn't treat. Also, this patient have a surgical resection of a brain metastasis, and when he represents for mapping for stereotactic radiation, it showed other diffusion-weighted images scans that shows ischemic changes in the contralateral side that would warrant us to wait and see and watch for this before proceeding and treat the cavity to make sure that this is not presenting a new metastasis lesions. With that, I think for the sake of time, I would close my talk. I think it's very long.
Yeah. Well, thank you so much. That is, we have very interesting questions actually. If you are...
yeah, sure. If there is time, I just don't realize the time.
Just a couple of minutes.
Sure.
The first question is about treating pituitary tumors. I don't know whether you are treating pituitary tumor. Is it okay to ask you about that? But like if the distance from chiasma is 3 millimeter, but in PTV margin, it's almost 1 millimeter. So how often you accept underdosage and to shifting to fractionated radiotherapy like 54 gray in 28 fractions? So is it okay if we give a PTV margin of 1 millimeter, although the distance, like sometimes the chiasma is very close to the pituitary?
So the chiasm metric should be less than 8 gray, and it should be respected really, because maybe you could argue to exceed the dose a little bit for the optic nerves, but not the chiasm. And it should be less than 80 gray really. No dose max at this side. But I can't understand the part of the pituitary. Is he asking about pituitary metastasis specifically?
Okay, the next question is, I'm sorry, we have very like a short time.
Yeah.
And the second question is how you select to give cavity SRS boost post-surgery with no residual disease.
With no residual disease, we should delineate the cavity with any surgical changes and enhancement and prescribe to 25 gray in 5 fractions. If there is residual, you could boost up to 30 gray for the residual only. 2 millimeter PTV to this.
Okay, thank you. And the next question is, what is your common regimen for post-op RT for brain mets at Harvard, Brigham and Women, and any size cutoff you are using?
Yes, it's 25 in 5 fractions. I think it's the same for the previous questions, 2 millimeter PTV.
Okay, great. Yeah, if there are other questions, I'll definitely send you an email. And thank you so much for your time. I know this is quite late in Boston. Enjoy your weekend and take very good care of yourself. Thank you so much.
Thank you, everyone. My pleasure. Thank you. Have a great night.
Thank you. Bye-bye. So our next speaker is Dr. Azad Rasheed. Dr. Azad Rasheed is a very prominent radiation oncologist in Pakistan. He is the pioneers of stereotactic radiation in Karachi, Pakistan. He spearheaded the first gamma knife unit, and he's the senior faculty member at CPSP, has a lot of publications under his name, is reviewer for a lot of peer-reviewed journals, and is so helpful and is always ready to help in his capacity. So welcome, Dr. Azad.
Very much, Mohsen. Thanks for elaborated introduction as well. I'm just sharing my screen with the device.
Thank you. It's all yours now.
Thank you very much, Mohsen. So many thanks for inviting me to share my experience on gamma knife radiosurgery in Pakistan. You can see my slides?
Yeah, now we can hear you and we can see your slides. Thank you.
Okay, that's great. Okay, I'm just starting again from a history and scope of a presentation. And this is what actually I just highlighted. The International Stereotactic Radiosurgery Society is a good resource for radiosurgery. And they have recently uploaded history of radiosurgery on their website. And I pulled out the history from there. In 1895, ionizing radiation was first discovered by William Röntgen at Würzburg. And this was the first discovery regarding radiation. And 1906, 1914, the stereotactic frame, they were in use. And this is what actually I just pulled out the points that showed that how radiosurgery was invented. And stereotactic radiosurgery, Horsley Clark, originally that was used in the animal studies, and later on this was combined with stereotactic frames and radiation in 1950 by Lars Lexer, and they start using it in normal routine clinical use. And later in 1967 and 68, they published our data with the case in the functional disorder. So this was slightly a review of the history given on their website. The definition of stereotactic radiosurgery somehow was the one where the Lars Lexer, this picture is showing this. The stereotactic radiosurgery was coined by Lars Lexer. He was a neurosurgeon at Karolinska Institute. He was using the same technique of stereotaxy with radiation therapy. Moreover, I would say that stereotaxy is a domain of neurosurgeons and radiosurgery that came up with a radiation oncologist. And stereotactic radiosurgery is a minimally invasive form of surgical intervention which makes use of 3D coordinate system to locate small targets inside the brain or body to perform on them some intervention. That intervention may be an ablation, a biopsy, lesion, injection, stimulations, implantations, and then afterwards people start using it as a radiosurgery, which is SRS. The definition of stereotactic radiosurgery is a high dose and a relative dose of ionizing radiation to the focused target with stereotactic localization, these coordinate system, that is a 3D coordinate system, and that target may elicit a specific radiobiologic response, and that may be seen over here that the single-stranded breaks or double-stranded breaks can happen into the DNA injuries. Moreover, there is cellular pathways initiating within the cell, giving a kind of responses in the form of the apoptosis or cell cycle arrest or other signaling pathway initiations, and having a high peak dose in the target and giving a kind of lesioning into this one. And it was historically happened in this way, that with the frame applying the single session. This is what actually Lars Lexer was using since long. Later on, the revised definition of stereotactic radiosurgery was emerged with the single setup. They went into the multi-fractionated radiosurgery. Astro, AANS, CNS, they all agreed about defining SRS in a way that includes both traditional single-dose SRS as well as multi-dose SRS. And this was actually later on come up with the definition that 1 to 5, whatever you are using, is being taken as a hypofractionation, which is used as a stereotactic radiosurgery. This is the development of evolution of gamma knife units. This is the first unit, prototype unit, and we can see that the imaging at that point in time was frankly using as a CT scan. And soon after, we see that the development of the all the models in the gamma knife history, they were improving, and simultaneously the imaging techniques, they were also improving along with that. CT afterwards, there was MRI and then PET-CT scan, which was having a very good study to point out the metabolic points and to radiate them. And then DTI for the tensor studies, which is actually for the tractography. And then you have a good staining of the lesion as well. So the development of the machine was based upon more like imaging development as well. These are the gamma knife models, and you see in 1968, proto unit was there, 1 collimeter, and then later on, this is the development. In 1987, there was a model U with 4 collimeters, 201 sources. The setup, this is important, collimeter setup time was 7 minutes, so it was taking a long time to change the collimeters and to get the treatment done. And later on, development was done in the easy reloading of that collimeters, more or less the similar setup. And then they have model C, where one thing they get into, which was actually 2 minutes time, collimeters changing time, 4 collimeters. This was APS, called as automated positioning system. So from manual reloading, they came up to somewhere automatic positioning system. And then it was refined slightly in 2005 with the LCDs open on this. The other setup was remained there. The time of changing collimeter was still 2 minutes. Later, there was a game changer, fully automated unit came up, which was called as the Perfection in 2006. The total number of sources was 192 and having a patient positioning system. And now the time setup was only 4 seconds that any collimeter can be changed. This was a fully automated setup of Perfection, came up in 2006. Later, another model, which is a currently most modern model of gamma knife, called as Icon unit, and it is having a similar constitution of similar kind of contents of Perfection, but having additional tool, which is cone beam CT for any kind of multiplicity, any kind of verification, motion management, and having an option of multi-fractionated frameless treatment. So these were the 2 to 3 developments which came up after Perfection model. This is the data actually given on Lexel Gamma Knife Society, and has shown that 13 million patients have been treated in year 2019. And overall, if we see that 95,000 patients per year are being treated, and this is a comprehensive data from 1991 to 2019. And if you see that what is the groups of pathologies they have been treating, the benign lesions in the new functional disorders, malignant tumors, ocular disorders, and vascular disorders, these are actually increasing number of indications being treated every year. And if you see that over here is a rapid track increasing steeply. The individual volume bulk increasing in the treatment indications for benign lesions was 24, and malignant lesions, they increased from 2014 to 2019 in 38%. Functional disorders 13%, ocular lesions 54%, and vascular 11%, is showing the huge volume of different indications increasing day by day on gamma knife radiosurgery. And if we see that from 2016 to 19 is a steep rise in the number of patients. And probably that may be the reason that from 2006, we have got Lexel Gamma Knife, which was a perfection unit. But in 2015, from here onward, we have increased number of tumors to treat in the form of the size when we have fractionation. So they start using the larger lesions. And another thing that they were having the motion management system. So the fractionation and the indication both increases a lot of number of treatments on gamma knife radiosurgery units. This is the global distribution of use of gamma knife radiosurgery. We see that 35.5% are Asian, and if we just include the Japanese into it, it is somewhere around more than 45, around 50% gamma knife is being treated in Asian countries. Later on, with the Europe and North America, they are the ones who are using gamma knife in this way. Coming towards Pakistan, this is a man who is Professor Azad Rasheed, who was the pioneer of gamma knife radiosurgery in Pakistan. He brought this unit. Initially, it was a 4C model, which was installed in 2008. And he also brought the IMRT BMAD with micro MLC with code CT Sbrt in 2009 in the same hospital. And this is our website of the hospital, showing that gamma knife, Linux, and PET CT scan all are equipped in this place. These are the therapeutic units at Ncci. You see, these are the two pictures of our hospital. This is the first unit, which is a Linux. It's installed in 2009. This is the second unit installed last year. And this is Icon, which was replaced. 4C was replaced with Icon in 2016. And imaging backup, we do have PET CT scanner with 60 slicer CT and 90 cm bore Toshiba CT scanner 16 slicer, MRI 1.5 Tesla Toshiba, and another MRI of 0.3 Tesla is available in this institution. This is a 4C model, which was initially came up in Pakistan, and this model was having a manual MLCs, and this was helmet-shaped MLCs having 4, 8, 14, and 18 millimeter bore. You can see this was the collimeter size, and these were the trolleys having this helmet, and it was manually uploaded in the system at that point. And this is how we were doing that. This is MR localizer, this is CT localizer, and this is a trolley. That trolley had to manually push towards this machine, and this was loaded automatically, but it was taking a long time again to change over different collimeters, particularly for those lesions which were small and close to the brainstem or close to the optic chiasma. We need a smaller collimeters, and that is what actually was taking a long time to treat the patient. And this is the model picture is showing different components: protective shielding, collimeter channels, Lexel coordinate frame, isocenter target, patient position system, and radiation sources. And this for model C, this was all replaced by model Perfection, which was a game changer and having all the automated system, which is actually different sectors having 192 sources of cobalt. And the game changer was the manual system changes to automatic, APS changes to PPS, 201 sources changes to 192, and there was 3 collimeters having 8 sectors with 24 cobalt sources, and there was the only changing time was 4 seconds. And then afterwards, this Perfection was changed to Icon Gamma Knife having CBCT and the same configuration of Perfection, but the additional benefit of multi-fraction, frameless treatments, and all the accuracies of motion management. And this is the unit installed at Gamma Knife unit at R70. And this is the same flooded with the collimator. This is a workflow. You just apply the frame if you want to have the frame treatment, and then to get MRI, the co-registration and planning. It is optional to get CBCT with frame. Usually we are not getting that one. Historically, we are treating with the frame and not getting CBCT, dose evaluation and treatment. But if we have this thermoplastic sheet, which is a new development on gamma knife units, that multi-session can be done. So this thermoplastic sheet, if we use thermoplastic sheets, then apply the thermoplastic, get an MRI, co-register, and then CBCT is must, and then dose evaluation and then the treatment. So this is a simple thermoplastic sheet which we usually using in the radiotherapy departments. This is a cone beam CT internal structure, and the 200-degree scan is getting all the way like other cone beam CTs. And this is a high definition motion management in this system. There is an infrared based tracking system lying on the foot end of the patient, and there are the sensors placed on the head end and the nose of the patient. And usually they are detecting the motion if there is any. And this is a continuous monitoring during the dose delivery, and movement outside limit will initiate sector off, integrated in the control system. And this is the graphical representation. If we just place 0.5 as a cut end, it will show us that wherever it is going up, the sector will get off. The one sector, there are 8 sectors of 24 sources. One sector will cut off, and that will be stopping the machine in that way. So it's up to us that how much limit we can assign, either 1 millimeter or 0.5, whatever we want to. Now, coming to the indications of gamma knife radiosurgery, there's a huge number of cases nowadays people are dealing with in the brain. The primary main categories are the benign lesions, meningioma, pituitaries, acoustics, cranios, glomus, spinal region, and chordomas. In brain, malignant tumors, brain metastases, recurrent gliomas, and in nasopharyngeal extensions, and others, psychiatric illnesses, ocular lesions, functional lesions, and vascular lesions. They are again a huge number that people are treating on that. Those prescriptions usually account for single or multi-session. You need to know the primary 4 things: the type of the tumor, size of the tumor, location of the tumor in relation to the critical organ, and knowledge about the critical organ tolerances. The type of the tumor, generally we see that the well-confined small lesions having good outline borders, that can be treated with a single session. While if we see that there is a subclinical disease or spillovers, and we need to go for the multi-session at that point in time. So selection regarding the type of the tumor is important to understand. The size of the tumor, generally 1 to 3 centimeters, being taken as German standard for single session stereotactic radiosurgery, while multi-session is for the larger lesions, or surgery or single session is a combination, which we need to know about the volume of the disease. Moreover, the location of the tumor is another important criteria. If we have less than 3 millimeter, we can go for the single session. But if we have critical organ lying overlapping the tumor or embedding or into it, we have to go for the suitable for the multi-session treatments. The borderline lesions, that can be taken as the GTV must be all the way combined in the high dose area, while PTV can be spared somehow, because the BED, if you see that for the radiosurgery, is more or less being achieved, whatever we are achieving in the pathology in the standard fractionation schedules. This is RDT1, and we are generally following this one. This is a very common and simple and easiest way that we are following in brain. For single session, we do have this kind of tolerances, 5 sessions and 3 sessions. So these are generally opted in the clinical settings. And then coming towards the planning, we do have a kind of 2 definitions: conformity and selectivity. Conformity is relevant with the tumor, and selectivity is the fall off of the tumor. High conformity, and this you can see, this is high conformity but low selectivity. And in this planning, you see high conformity as well as a high selectivity. The brainstem is spared. You can see the different isobrosis spread is very small, and over here the spread is very huge. The plan evaluation tools, gradient index and pedic index, they are always available in the gamma system, LGP, and that you can calculate right at that moment when you are planning. This is co-registration. Definition is like any stereotactic study can be fused with the non-stereotactic study, labeled as a co-registration, and we can fuse MRI with CT and PET-CT with CT and angiography with CT or MR, whatever we want to fuse. The system allows us to have it. This is a beautiful confined doses. Yellow line is generally 50% isodose line, which is a prescription isodose line in gamma knife radiosurgery. And this green is generally 20%. We used to see that how much fall off is going away from the target prescription isodose line. And these are the red areas which are inside. These are called as the shots. These are circular isodoses coming into it, and we have the system options to make them controlled by ourselves. I will show you in this kind of blocking. This is a manual blocking system where it was placed by yourself every time. And this is now in Icon automatic blocking system, 4, 8, and 16 millimeter collimeters. You have this system, and you can change your isobrosis very decently. This is one meningioma line over here. This is the brain stem, and you see that if we have a kind of low dose isodoses, you can simply move them away from the brainstem, and the more doses can divert towards others. So this is the automatic planning system, and you can see within the planner can do and manipulate all that. The summary of radiation treatments at neurospinal cancer care at our center. In last 9 months, we have treated on from January to August. Gamma knife surgery, we did 152 cases, and on Lenic we did 214 cases, a total 366 cases. And this is the division of our machine. On Synergy and Gamma knife, we have been treating, and every month it's like 20-25 patients on each machine. And this is the indication we treated on Synergy in last 9 months. And this is a gamma knife cases. And different pathologies you can see that are a kind of 20 different pathologies presented to us in these last 9 months. So in Pakistan, we have the similar kind of distribution of indications, what actually the rest of the world is using on gamma knife. Up till now, in 2010 to 19, we have treated like more than 2,500 cases. 4890 were the male and 1197 were the female. I've tabulated again in the form of the grouping. The benign lesion 1300, malignant 650, vascular lesion 528, function 124, final lesion were 85 cases. And this is the age range from 3 years to 8 years. All the age range was catered. The most prominent group was 31 to 40 years. And this is the referring physician, that who are actually referring the patients to us. These are neurosurgeons, clinical radiation oncologists, or any others, including ENT, thoracic surgeons, ENT or neurophysicians, and others who are sending us the cases. And we find out the benign lesions predominantly referred by the neurosurgeon, malignant also again the neurosurgeon. And if you see the neurosurgeons, they are the primary referral for gamma knife radiosurgery. And after them, the clinical radiation oncologists, they are the one who are sending a patient for radiosurgery. But that tells us that the neurosurgeon, whenever they have difficulties in treating some deep lesions and having other problems with the surgery, or having the huge residuals or other indications, they used to refer the cases for gamma knife for non-invasive treatments. And this is how we are taking the patient with tissue and without tissue diagnosis. Most of the time, benign lesions, we are treating comprehensively on radiologic findings with a non-invasive, particularly the vestibular schwannomas and meningiomas, we used to treat on radiologic grounds. And if we have tissue diagnosis, and you can see that in benign lesions, we do have 40% histologies, while 60% were the radiologic treatments. In malignant, we do have predominantly tissue diagnosis with us, and there are few where we can't get the surgery done. We still have 30% treated without that. On radiologic grounds, we are treating on them. Vascular and functional, they all are getting radiologic and angiographical diagnosis, so they are in the same way we are treating. For pinary region tumors, we used to have, it's a difficult place for the biopsy, so generally we are treating 75% without biopsy on that. And we have treated a good performance status predominantly. Single lesions were treated most of the time. And the location of the lesion in the brain, you can see comprehensively, supra-infra, or right and left hemispheres, all are available in this one. And the doses, we use generally 12.5 to 25 gray. And we predominantly we are using 50% isodose line as a prescription isodose line of gamma knife. This is actually the mask and frame-based treatments. I pulled out these two from the Gamma Lexel Society that the word using, they're using mask for single session in a way that you can see the single session 36%, the rest of the world is using mask, and 73% with the frame. But you see that for multi-session, even they are using mask and frame as well. So they are using frame for multi-session. But generally, we are not using frame for multi-session. For frame, we are having 100% single session with this one and multi-session with the mask. So this is how we have seen, we have selected the patient that, generally when apply the mask, when patient is claustrophobic other than or don't want any kind of frame. And we know that trigeminal neuralgia are small other lesions. We use the frame at that point in time. And this is how many times we use the number of fractions. The 5 fractions generally we are using, and there are few in which we have used 2, 3, or 4 fractions, or sometimes 6 to 10 fractions. So as a summary for gamma knife stereotactic radiosurgery, NCCI developed a state-of-the-art services and of gamma knife in Pakistan at par with international standards using modern imaging backups. The department is now accredited from CPSP for postgraduate training of CPS, and GKSRS is providing excellent non-invasive backup for neurosurgeons and radiation oncologists to treat brain tumors. I pulled out a few things over here that the literary and academic activities at NCCI. We used to have symposium, workshops, and we are having regular newsletter as well for any information within the Pakistan about gamma knife or other stereotactic radiosurgery. We are available every time. This is the worldwide Lexel Gamma Knife Society website. It's a very good resource for gamma knife studies, and all the education resource is lying over there. And these are different books, and this is the material is always available on this website. And the people who are starting on stereotactic, they can have all these kind of guidelines. You see ISRS, IRSA, and Stereotactic Radiosurgery Societies all are the primary source for radiosurgical guidelines you can use on them. This is European Gamma Knife Society, and they have their annual meetings. Postponed in 2020, will be in Romania in 2021. And this is again Stereotactic Radiosurgery Society. They are issuing their journal as well for radiosurgery, so you can have your publication right over there. And this is
yeah, well, thank you so much, Dr. Azhar. This was wonderful, and we all enjoyed your presentation. You are doing an excellent job and probably have the largest database in Pakistan. And we hope to get a lot of other good presentations from you as well.
Thank you very much.
Thank you so much for your time. I have one question for you because of shortage of time. How do you differentiate pseudo progression from real progression post SRS?
Generally, we are tracking in the same way as in radiation oncology. That we do have MRI, MRS. If the patient is not willing for any kind of surgery, we used to have MR, MS, and we do have PET CT as well. And with this one, our radiologists, they are giving us the backup, and we used to find out. Most of the time we drag the patient because this is a small volume disease generally, and we track them and keep them on steroids and giving sometimes Avastin as a post-radiation necrosis changes. And if we are sure that for a certain sequential imaging, we see that it is still not resolving, we used to re-radiate for that one. So that pseudo progression detected in serial scanning and with the help of different studies, MRS, DWI, or other imaging.
Well, thank you so much, Dr. Azhar, again, and hope to catch you sooner. Take very good care of yourself. Our last, thank you. Bye. And our last speaker is Ms. Mahnaz Qamar, who is chief medical physicist at Shaukat Khanum Memorial Cancer Hospital. She is American board certified in medical physics from the College of Radiology, and she has contributed significantly in starting our service of Sbrt SRS at Shaukat Khanum. She will present us physics perspectives of stereotactic radiation therapy. Welcome, Ms. Mahnaz, and its podium is yours now. Thank you.
Thank you very much, Dr. Mohsen. Thank you to the organizers and Dr. Mohsen for giving me a chance to present my talk. I'm gonna share my screen now. Can you see the screen? Can you see the slides?
Yes, we can.
Okay. Today I'm going to be talking about the physicist role in the implementation of stereotactic radiosurgery in a radiotherapy department. There has been a lot of interest lately in Pakistan, even though this technology is not really new, and especially Linac-based radiosurgery. So I will be talking about, what is the physicist role and what are the things you need to be careful of before you implement such a complicated technology. So I'm going to be referring a lot to the ASTRO ACR practice parameters. According to the ACR Astro practice parameters for SRS Sbrt, the medical physicist is responsible for the technical aspect of radiosurgery and must be available for consultation throughout the entire procedure, from imaging, treatment planning to dose delivery. They have to do the, before the equipment can be safely used for treatment, they have to implement all the, they have to do the acceptance testing, be involved in acceptance testing, do the commissioning, develop a QA program, and develop a comprehensive safety mechanism from the start to the end of treatment. And they have to basically either perform or supervise treatment planning and provide supervision at different levels, whether it be the treatment planning or treatment delivery. So, so there are some resources that are needed. One of the main resources is the adequate medical physics staffing to ensure that an experienced physicist with appropriate SRS Sbrt training is available to oversee the different aspect of the program in relation, in collaboration with the lead radiation oncologist, of course, or in physics or dosimetrists with appropriate SRS Sbrt planning training who can devote enough time which is necessary to develop a good treatment plan. And basically, who are able to do a comprehensive review of all the technical aspects, which involved multimodality imaging, fusion, registration, and to determine if there are any potential limitations in the safe delivery of that treatment. In addition to obviously, trained experts, you need some equipment or instrumentation to actually be able to validate the whole system. And one of the most common ones are the radiation detectors, since we're, everyone knows we're dealing with very small field sizes and very small apertures. So, the regular detectors that we often use in clinic are not suitable. So in order to commission the system for adequately measuring the small and basically commissioning small fields and apertures, we need to, whether it's MLCs or cones, we need really suitable micro detectors. And also reference grade electrometers, which are able to detect the really small signals from these very small apertures. We need, and everyone must have heard this term a lot, the end-to-end process, where there are certain phantoms available that can basically simulate the treatment, starting from the CT to imaging studies like MRI or PET, the treatment planning and treatment delivery, and be able to incorporate all the discrepancies or all the inherent errors in that system and give us a final error. And then we have to determine if that error is safe, depending on the scope of treatment that we're performing. Then we need some QA devices to perform the Winston Lutz test, which is basically the check of the radiation isocentricity of beam alignment. And it actually basically checks the coincidence of, these days, the imaging system and the radiation isocenter. So, in addition to that, we need adequate simulation, treatment planning, and treatment delivery resources. So they include appropriate devices for patient setup in immobilization, for proper motion management, if our services are going to include areas where there is motion of the treatment site, computerized treatment verification systems, access to MRI imaging and other imaging modalities, basically capability to characterize and quantify internal anatomical changes with respiratory motion, image fusion capability within the treatment planning system, and basically, if the patient has had previous treatment, the capability to calculate, display, and evaluate composite doses. And if, depending on the scope of services, if the hospital is planning to treat both intracranial and extracranial treatments, then we need a LIDAC-based treatment delivery system with appropriate mechanical accuracy, field size, and resolution for small conformality and image guidance devices. Also, in addition to that, we need, in a department starting these services, we need administrative support. What does that mean? That means their commitment to support the delineation of duties and procedure-specific QAs and staff authority for a safe delivery of these services. And who will, who would support in defining certain SOPs developed by the institution's physicist and the lead radiation oncologist, and which are consistent with the institution's credentialing process. And then commitment to facilitate a peer review of the program, either because if it's a new program and no one is experienced, either on-site proctoring of the first treatments, if the clinical team does not have prior experience, and our commitment to support ongoing training for members of the SRS-Sbrt team, and then continuing credentialing of the rest of the staff. And if there are turnovers within the department, then that it's also necessitated by the if there's more turnover, then you need more training of the newer staff. And also, in addition to that, because these are really sensitive machines, you need a robust preventive maintenance program and service support, because if there's only, let's say, one system which provides which is commissioned for SRS and Sbrt, if there is no backup, then you would want fast service support so that the system is not down for longer than it absolutely necessary. So the role of the physicist actually does not start after the machine is installed. It actually starts well in advance when the decision of selecting such a modality is being made. So the physicist who has had experience must be involved in the process of facility design and equipment selection and specifications, so that basically nothing is missed. And they basically, what they do in the acceptance and testing and commissioning process is provide direct supervision during the acceptance, because the acceptance, when they're accepting the machine from the vendor, then they work closely with the installer and their engineers to perform the acceptance testing process, where the vendor demonstrates acceptable system performance, some of which then forms the basis of the components during the establishment of the routine QA and the commissioning process. So if we accept, for example, if we accept the machine at very the edge of tolerances, then it would be hard to maintain that. And then really, once you accept it, it's not easy to go back and then ask them to, let's say, tighten the system or rechange the tolerances. So what is commissioning? The qualified medical physicist must understand the scope of SRS-Sbrt services to be provided. So there is regular commissioning, which which is performed for regular radiotherapy machines, and then there are specific needs if that machine is to be used for these highly focused treatments like SRS and Sbrt. So the commissioning process includes the overall process of validating the planning and delivery system for the services to be offered and developing appropriate QC and technical procedures. So what is commissioning? Is it just for the machine or the Linux, or it's actually basically all the equipment that is going to be used in that process. So which includes the treatment delivery system, the immobilization devices, and ancillary systems for imaging and motion management. So any system that we're using for, let's say, MR, so there has to be some kind of background QA checks for that also. If it's, if the images received from that system are going to be, accurate enough, because all the tumor delineation is performed on those images. And of course, the main part, one of the main parts of this system is the treatment planning systems. So the commissioning process includes the equipment commissioning and then the process commissioning, basically the commissioning of the whole process from patient selection to the patient treatment and clinical implementation. So we all know we've had wonderful presentations before. Some of the equipment used today for the treatment of SRS, Sbrt. So who performs the commissioning is performed by physics teams after initial acceptance. So once they get together with the installation engineer and does an initial acceptance testing, then comes the major part that is performed by the physics team, where they establish baseline characterization of the performance of the system, which then form the basis of the future QA, the periodic QAs. At that time, they have to define the limitations of the system, depending what kind of applications it's going to be used for. It includes the specific validation of equipment like MLCs or micro MLCs or cones used for SRS Sbrt, special data collection for dosimetry conditions like very small field sizes, which is often referred to as small field dosimetry, and data collection for a lot of these equipments have a flattening filter-free beam. So having an understanding of what that, those are, and basically being able to commission them for the system. So before, we get into that, so there is a lot of documentation available for the physicists to go through. So they should go through that and have a good understanding of what is needed and what they can foresee. And there's a lot of literature available, so refer to that. I mentioned equipment. So some of the equipment we can see here, these are some of the chambers, the microchambers, and then the diodes. Even, these days the fields are so small, some of the microchambers can introduce errors. So you really have to go to the literature, look at the, there's a bunch of literature available, which there actually gives you data for the different type of chambers. And, there have been studies done on those. So what is more common these days are the solid state microdetectors, such as diodes, plastic scintillators, and synthetic microdiamonds with appropriate characteristics for small field dosimetry. And some of the, there are reference grade electrometers which can detect low signals. So when doing patient specific QA, you're actually able to really measure the dose properly. And in addition to those, we of course have the scanning systems, and there's the same ones that are used for the regular commissioning of the machine, except they are retrofitted with not retrofitted, but they're equipped with these, small volume detectors. So one of the very common characteristics, or the important characteristics that we need to be aware of any detector is used for commissioning of SRS Sbrt fields, is that the detector's active area should be of a small size compared to the field size range to be characterized. A daisy chain method is recommended using 2 independent detectors suitable for measuring small field. What that means is that you would use a regular size or regular volume detector to measure, let's say for field sizes 10 to above, and then a small volume detector to go back from 10 or even 12 or 15 and go back all the way down to 2 by 2 or smaller fields. And then we have these end-to-end phantoms. A lot of manufacturers provide those, which are again to basically, they're used to validate the process from the beginning to the end, let's say from the patient CT to the MR, treatment planning and delivery. So again, for equipment commissioning, there are several societies or that have guidelines which can be followed, and they're both about the commissioning to the choice of detectors, detector comparison that needs to be really thoroughly looked at before the selection of the equipment. Another important aspect is the treatment, is the, when you measure the data, are you confident that what you're measuring is good? So, and that, because you're suddenly using these very small field sizes and then you're using these newer detectors. So the question arises, are you using the right detector for that, that mode? So basically what you can do is you can get your data, and if you have a prior machine commissioned, you can actually compare the data from the data of that machine, or you can compare it to the data from other institutions for similarly designed machines, or a lot of times the vendors will provide you like a standard data that you can compare and gain confidence in your measurements. So for end-to-end testing, basically what you do is in end-to-end testing when you're commissioning a LINAC is for SRS Sbrt, you would basically get a phantom and then place it into conditions similar to what you're going to be using for your patient treatment delivery. Like in this case, you're using the same face mask and same immobilization system to immobilize, and basically you build a plan on that phantom. You do an imaging study of that phantom, and then you fuse those, and then you deliver the same treatment, and then you're actually, while you're delivering, you're measuring the dose and then calculating it to compare it with what is your expected dose from the planning system. So this is one of the end-to-end tests that we ran initially, and these are what's going on while it's delivering. This is kind of fast, but this is going on one of the recent brain mets that we treated. This is an end-to-end testing going on. For then, you have to check the isocenter accuracy of your machine with the famous Winston Lutz test. There are different ways of doing it. So there are different ways of doing it. Different phantoms are available in the market where you can image and then send the images to your system that analyzes the isocenter accuracy and come up with a number. So this is required to be done before every patient treatment. Again, immobilization devices, you have to look at the immobilization devices which are recommended, and judge their effective and target accuracy and precision. And also, more importantly, sometimes you have to look at their attenuation and surface dose characteristic, make sure there is no buildup of dose where there is a, at the junction. Treatment planning systems. I think I'm running short on time, so I'm going to quickly go through this. The commissioning of the treatment planning system should include additional validation tests as appropriate for specific Sbrt, SRS delivery. They should evaluate a multimodality fusion, and then, special validation of the small field sizes or small apertures being used, and heterogeneity connection, and also the validation of special algorithms such as Accurus, which will be used for extracranial SRS Sbrt. This is recommended for your end-to-end in the system imaging QA to use motion systems. These are really pretty expensive, so you can actually use these homemade sort of devices, not really homemade, but you can use the simpler systems provided with the machine to develop those. Process commissioning is where you basically develop and validation of the technical process to be followed. So it's not just the machine, but the whole process. And then SOS, the SOPs are adhered to. So you should develop SOPs for every site to be treated. And then basically the QA processes and procedures related to SRS Sbrt should be should be designed to cover the following aspects of the program: the equipment specific QA, the patient specific QA, the procedure specific QA, and safety and QA recommendations have been extensively described in these following basically publications. Thank you.
Oh, thank you so much.
I'm done, right?
Wow, what a timing. So
rushing through.
Thank you so much, Mahnaz, for this wonderful physics insight into SRS program. I have a couple of questions. If you have, we have a couple of minutes now. So the first question is, what reference FMEA do SKM use for a new radiosurgery service?
I'm sorry?
What reference FMEA do SKM use, like failure mode and effect analysis, do SKM use for a new radiosurgery service?
I mean, like on physics-wise, or?
Yeah.
So we basically, we use the Astro and APM guidelines. That's what we use for, for our data. So that's what we mainly use: the Astro, the APM guidelines, their SRS Sbrt, the reference that I just showed.
Okay, great.
Yes.
Well, I thank you all the participants and especially the speakers for gracing us with this wonderful joining of the sessions, and I wish you all the best for the rest of the weekend.
Thank you.
Take care and bye-bye.
Thank you.